All right, PD's part 2. So picking up where I left off, pediatric competencies. The children must be 6 years old or younger to count for your pediatric comps. PD chest is mandatory. It can be 6-year-old or under. So you could do an infant. You can do, PD in a pigastat, or you can pick a 6-year-old and do either AP or PA in a lateral standing if they're really cooperative. If you get a 6-year-old who's being cooperative in the waiting room for a chest, take that one. PD abdomen's elective. Upper extremity, lower extremity, those are elective, and it can be any. And then the mobile chest study for pediatrics we do in the NICU, and we have that as a mandatory elective for our program. So pediatric chest, you've got some options, and I went through these options as well in the pediatric chest lab handout. But if the child can hold their head up for about 2 to 3 months old, you can use the pigastat. If they can't sit up, if they can't hold their head up on their own, you're going to do it supine, AP, and then lateral laying down either on the tabletop or in the table bucky. If possible, take the grid out of whatever you're using. I think 3300 Main Street is the only area where we can't take the grid out of at least the wall stand. So, but if you can take the grid out, it decreases the dose as much as 5 times. Obviously, right, your average table bucky or wall bucky grid is either a 10 to 12 or 10 to 1 or a 12 to 1 grid. And those are a factor of 5. So children 4 to 6, if they can stand for you, you can do it AP. If you think PA will be difficult, if you think they'll be looking around or moving around, we can do it AP, and the radiologists are okay with that. If they can't stand, but they're too big for the pigastat, you can sit them on a sponge at the end of the table, and you can use a cassette holder in the parent to kind of hold the cassette behind them. And I'll talk a little bit more about that in your lab handout as well. But if you're phototiming against the wall stand, you can use center cell for all your PD chests, because the children, they're just not wide enough to hit the outer cells. So you're not going to get an appropriate penetration because they're not over those cells, right, where they should be. So just use center cell for both PA and lateral, and just explain everything clearly to the parents. Make sure the parents are shielded. So this top image here is sort of demonstrating a child. He's maybe too big for the pigastat, but too wiggly to stand. So I put a little sponge underneath him to raise him up off the table. We do not have this fancy dancy cassette holder. But you can utilize the cassette holder that we do have. You can put it behind and then up next to them for the lateral and just do it tabletop. This is a bit of an older child. You can do it PA, and definitely have them hold on. It keeps them a little bit more steady. Example of the pigastat, doing an AP, I would always have the parent with them. I wouldn't leave them alone without a parent, as in this picture here, but this is a doll, so I'm not too worried about the doll. But these pigastats can be used with the DR wall equipment. You want to shield the parent that is staying in with the child. Slide the pigastat right up against the wall stand. Select pediatric settings on the control panel. I always say wait for the end of the scream, because children, when they're upset in this pigastat, they're really annoyed. You're holding them still. They don't want to be here. They don't feel good. They're going to sort of cry, a long cry or a scream. And after the long cry is when they take the deep breath in to do their next cry. So wait for after the scream or after the cry. And that's when they're going to take a deep breath for you. So try and time that. Swallowed foreign bodies. We do a lot of foreign body pediatric exams. So they love to swallow coins, which can be potentially lodged in their airway. And usually the right main bronchus is the primary location for any aspirated foreign bodies. And that's always sort of a fun board question too. So keep that one in your notes. If the child is small enough to fit on one film, we have a nose to rectum order. So your light literally has to go at their nose and to their rectum. If they don't fit on one, we can't use this order. We have to do a chest to include upper airway and nose, and then an abdomen to overlap. they love to swallow all sorts of things. So this is like a SpongeBob something. This is a piece of a fidget spinner, and this is an older child. This is a teenage child, but I think that was by accident. If you ever played Jacks, that's what that little piece is there. They love to swallow all sorts of things. Keys getting lodged in there. We've done ornaments and magnets and pieces of games, anything. Bone age. We do, you'll see orders for bone age study. This is when the child is either sort of measuring a little bit below where they should be size-wise or a little bit above where they should be. So they send them in for a bone age study, and it's a left hand to include the wrist. You want to make sure everything is straight on, that we're not clipping anything off. Try and tuck that thumb in a little bit, but you want to make sure you get a little bit of wrist on as well. And it's a one shot. You only need one of the left hand and wrist for bone age. Okay. And then the radiologists are going to do some measurements and determine what sort of bone development level that they are at. So they might be at a level younger than them, or they might be at a level older than them, depending on how they're growing. Okay. But this was just an example here of a lot of measurements going on in the involvement here. Flat down, in alignment. You know me, I like to have that hand, wrist, forearm all in a row here, and that's what they want. If they can't hold still, we have these clear plastic rectangles in the department that you can help sort of immobilize the fingers with. So if they're really having trouble keeping those fingers straight, you can use that. Try and keep the border of it out of your area of interest, because it will show a white line. So try not to have that white line right through like her carpal bones where you'd need to see. Unfortunately, a lot of pediatrics that we do is due to physical abuse. You may see the abbreviation NAT or NAI, which is non-accidental trauma or non-accidental injury. It's the leading cause of childhood traumatic injury and death in the United States. 80% of these deaths are from head trauma. 20% involve burns. 25 to 50% with fractures from physical abuse. And 10% of children under 5 years who are brought into the ER with alleged accidents have actually suffered from non-accidental trauma. So what does that mean? It means someone hurt this child, brought them to the emergency room with a fake story, and then we have determined that is actually due to abuse, that's why they're there. Pediatric bone surveys is something that we do anytime they are questioning non-accidental trauma. They're looking for specific type of fractures, potential fracture areas, healing fractures, maybe from an older incident. We do often repeat these a few weeks later, depending on the situation and what the fractures look like. They may have had a CAT scan already, looking at the skull. If it's a quality CAT scan with not a lot of motion, sometimes we can skip the skull x-rays to kind of reduce some of their radiation. There are something called babygram, and a babygram is an x-ray of the entire child on one image. And these are not acceptable, especially to our radiologists who are particular. Okay, we have to do cone down images of the areas specific to detail, and we are very aware of our technical factors here. So some common fractures consistent with non-accidental trauma. We're going to go through a little bit of these, but bucket fracture, corner fracture, ribs, acromion, spinous process, sternum, occipital impression fractures, and spiral fractures. Long bone fractures are usually due to direct blow or more commonly shear force. Rib fractures. They occur when a compressive force is applied to both the sternum and usually the posterior portion of the chest. So someone is holding the child's chest while compressing both front and back and shaking the child. So it's usually the posterior ribs are most commonly fractured. Usually the abuser's thumbs are on their chest wall and their fingers are on the posterior side of the child. and that causes the posterior rib fractures. Skull trauma, usually a direct impact to the skull. It usually leads to some intracranial injury, so some bleeding, some swelling. And these are sometimes accompanied with linear fractures being the most common, but you may see some bleeding and head trauma as well. Shaken baby syndrome. The babies have very weak neck muscles that can't fully support their large heads. So severe shaking causes the baby's head to move back and forth in their skull and get damaged. So it's seen primarily in children younger than 2, average 3 months to 8 months old. There's between 600 and 14 cases per year on average. It's also the most common cause of death and long-term disability in infants and young children who are victims of child abuse. These were some skull fracture images. Another skull fracture image here, and a femur fracture here. Fracture of the tibia, femur fracture here. These are demonstrating rib fractures. And you can see these ones are actually healed. These are healing rib fractures. They've got new bone. These are a significant amount of rib fractures on this child. There's also a clavicle fracture here. Bucket handle fractures. They are usually sometimes referred to as corner fractures, but they're most common in the tibia, distal femur, proximal humerus, and usually they're bilateral. Bone survey image protocol. So the protocol is set by your pediatric radiologist. You always check with the rad before starting. If you're on an off shift, the adult rad will read it as sort of a preliminary reading, but the pediatric radiologist will sign off on it when they come in, because they are the ones who will have to go to court if it does go to court. Try to leave the parents outside the room. It just goes a lot smoother if they are not a part of it. You also don't know if it's the parent causing the trauma. So it's really alleviates some stress and helps you move a little bit faster. Diapers need to come off for the pelvis, femur, and lumbar spine images. Diapers will cause an artifact. Selecting appropriate technical factors in histogram are super important. So there's a handout hanging in the miscellaneous rooms and in the ER for you guys for techniques on these. We do an AP and lateral skull and a lateral C-spine image. Sponges are key for this, okay? Be aware of the sponges. Try not to get your fingers in there. We're going to do a lateral T-spine / chest. So you have to get the sternum on and the back, make sure they're lateral, looking for lung fields, getting the arms up and out of the way. Lateral lumbar spine, nice and superimposed. And then we do an AP pelvis, which includes the AP of the lumbar spine. Make sure you turn the toes in just like an adult pelvis. We do an AP chest and 2 obliques. They are shallow obliques. Don't go crazy with your obliques. The arms need to be up and out of the way and not overlapping the sides. We do AP bilateral femurs and AP bilateral tib fibs. You need to include both joints anytime you're doing this imaging. So we need joint above and below. So you need to make sure we have the knee and the tip and the ankle joint, hip, knee joint, something like that. Okay. Feet. So in this image here, that's that clear plastic rectangle that you can see here causing a little bit of artifact. That's what I was talking about. But kids trying to help get their toes down is difficult, so use that. Bilateral humerus. Don't over-rotate externally for the humerus. Make sure that you're staying AP. Try not to turn that collimator. Include a little bit of the rib cage. AP forearms. Make sure you include elbow and wrist joints. And hands. Again, either tape hands or use that clear plastic. We have done some postmortem ones. Usually, if they're questioning, is it SIDS? These are really difficult for a lot of technologists as well, but our imaging is the same. So I'm going to stop there.